السلام عليكم ورحمة الله وبركاته. رجعنا لكم مرة تانية في الجزء الثاني من الكويز بتاع الكاليبريشن والكاليبريشن فيريفيكيشن والريبورتابل رينج. فضلا وليس امرا نعمل شير ولايك وسبسكرايب عشان الفيديو بتاعنا يوصل لأكبر عدد من الناس.
A TPO antibody test has an AMR of 0 to 150 IU/ml. The laboratory has validated a dilution protocol. The reportable range for the assay is 0-300 IU/ml. If a sample had an anti-TPO concentration of 1000 IU/ml and a 110 dilution was made, what should be the outcome? Please select the single best answer. 1. A 110 dilution would bring the sample to around 100 IU/ml and be within the AMR and reportable range. 2. A 120 dilution would be needed to bring the assay into the AMR. 3. Dilutions cannot be used when the AMR and reportable ranges are different. 4. The result should be reported as greater than 100 IU/ml. The answer: dilutions are useful when a result is outside of the reportable range or AMR. In this scenario, a 110 dilution should lower the concentration tenfold, bringing it within the AMR and reportable ranges, so a calculated result could be released. A 120 dilution is more than is needed to bring the analyte within range. Since the dilution will bring the result into the reportable range, a greater than sign should not be reported. At the request of physicians, a laboratorian validates a dilution protocol for her laboratory's ACTH assay. Which of the following would be true? Please select the single best answer. 1. If the analytical measurement range, AMR, or reportable range are extended, the assay becomes a laboratory-modified test, LMT. 2. The dilution would extend the AMR, but not the reportable range. 3. It is non-compliant to alter the reportable range or AMR for a commercial assay. 4. A dilution should only be used in samples that exceed the reportable range. The answer: dilution of samples can be used to extend the reporting range for an assay. It is compliant to extend the range if one validates the utility of the dilution protocol. But to do so renders the assay laboratory modified. When an assay is modified like this, it is no longer FDA approved since it is being used outside of the original specifications. Dilutions don't extend the AMR, they extend the reportable range. A body fluid assay for CEA has a validated range of 0 to 100 nanograms per milliliter. When the instrument reads greater than 100 nanograms per milliliter, a technologist performs a 110 dilution and reruns the sample, reporting the dilution-adjusted result in the patient's chart, though they will not dilute the sample further if the result is over 1000 nanograms per milliliter. What are the analytical measurement range, AMR, and reportable range for this assay? Please select the single best answer. 1. AMR and reportable range are both 0 to 100 nanograms per milliliter. 2. The AMR is 0 to 100 nanograms per milliliter, and the reportable range is 0 to 100,000 nanograms per milliliter. 3. The AMR is 0 to 100 nanograms per milliliter, and the reportable range is 0 to 1000 nanograms per milliliter. For the AMR and reportable range are both 0 to 1000 nanograms per milliliter. The answer: the AMR is the range that can be assessed without dilution. For this assay, the validated range is 0 to 100 nanograms per milliliter. However, the reportable range is the concentration that can be reported in the patient's chart with dilutions. This range goes from 0 nanograms per milliliter up to 1000 nanograms per milliliter. Which of the following is true concerning the extension of the analytical measurement range, AMR? Please select the single best answer. 1. Dilutions can be used, but the type of diluent must be validated. 2. The AMR can be extended to 10 times the reportable range, but no further. 3. The AMR can be extended only if the FDA approval for the test is maintained. 4. Dilutions can extend an AMR, but a concentration procedure cannot. Extension of the AMR can be achieved with a dilution or concentration protocol. If a dilution is used, the protocol for the dilution must be clearly defined and validated. This validation would obviously include validating the type of diluent to use. There are no theoretical limits to extending the AMR, it depends on the assay or instrument's signal measuring range. When a medical laboratory scientist calibrates or recalibrates an assay, what is actually being performed or being assessed? Please select the single best answer. 1. The QC is being evaluated against a peer group mean. 2. Within-day QC precision is being compared to within-day accuracy. 3. Proficiency testing samples are being reconciled to peer group means. 4. The relationship between the reagent/instrument response and the concentration of an analyte is being established. The answer. Calibration is a determination or redetermination of the relationship between the reagent system/instrument response and the corresponding concentration of an analyte. This is done by running calibrators of known concentration to realign or establish the performance of the assay. Without calibration, a quantitative assay is not able to predict unknown concentrations. None of the other choices describe calibration, but instead refer to other processes or actions around quality control. Calibration must be done before QC or in response to failed QC, but calibration cannot be done simply by evaluating QC. A hospital laboratory has two instruments that perform troponin testing. One is a high-sensitivity troponin assay that has an analytical measurement range, AMR, of 5 to 500 pg/ml. The other instrument runs a traditional troponin assay with an AMR of 0.01 to 100 nanograms per milliliter. Which of the following would be true? Please select the single best answer. 1. The two instruments must have comparison studies performed twice per year. 2. The AMR study samples for one instrument can be used for the other instrument. 3. These constitute different assays, and as such, they do not need to be compared. 4. The AMR check from one instrument can be used to complete the annual comparison study for the two instruments. The answer. These two tests are clearly different tests as evidenced by their very different AMRs. High-sensitivity troponin is not the same as a traditional TNI or TNT assay. Since these assays do not share the same AMR or even the same reporting units, it would not make sense to compare them to each other. While a patient's clinical outcomes with regard to each assay's result may be interesting to compare, the instrument values don't lend themselves to direct comparison nor harmonization. Since these are two distinctly different assays, twice-a-year comparison study is not needed. If such a study were needed, it would be twice a year, not annually. A laboratory supervisor receives a call from an irate physician who is complaining that when her patient had his creatinine measured at the hospital, the result was 5.2 milligrams per deciliter, but when reordered at a reference laboratory across town, the result was 2.7 milligrams per deciliter. The physician is wondering how the hospital laboratory resulted such a falsely high result. Which of the following is a reasonable response? Please select the single best answer. 1. Hospital laboratories tend to use faster, but less accurate, methods, and so the outside laboratory is likely the true result. 2. The hospital laboratory is not required to compare or harmonize results with another laboratory at a different address. Repeat testing of the patient should be performed to troubleshoot this discrepancy. 3. The two results are reasonably close given that they were from different tubes. 4. Hospitals are required by CLIA to be harmonized to reference laboratories located in the same geographic area, and so a root cause analysis should be undertaken to investigate the discrepancy. The answer. It is true that the hospital laboratory is not required to compare or harmonize results with another laboratory located at a different address. If the hospital and laboratory were part of the same system, i.e., owned and operated by the same agency, then periodic comparisons across the two sites would be reasonable but are not specifically required. CLIA does not require all laboratories in the same geographic to be harmonized. It is unknown which method is more accurate, or which result should be used. The difference between the two results is significant and should be investigated. Comparing the reference ranges from the two laboratories for creatinine may be a good first step. Repeat testing of the patient should be performed to troubleshoot if there is a true discrepancy. A regional health system uses portable point-of-care (POC) chemistry analyzers at multiple locations throughout the city. They also have a regional laboratory that performs centralized automated chemistry testing. Which of the following is required? Please select the single best answer. 1. The laboratory is required to compare the POC instruments with the main lab instruments once per year. 2. The laboratory is required to compare the POC instruments with the main lab instruments twice a year. 3. The laboratory is not required to compare these instruments since they are located at different locations. 4. The laboratory should do the same method region-wide to ensure harmonization of results. The answer. Laboratories are required to compare instruments that are housed within the same CLIA address. Comparisons across a regional system that has multiple sites, such as in this example, are not required and may not be feasible for extremely large systems. However, verifying that laboratory results are consistent across a health system is prudent since patients may access care at multiple locations and providers expect laboratory results to be commutable, but a strict twice-a-year comparison is not specifically required. Having a single method for a large or multi-site system is not required and may not be possible. A large volume laboratory has a backup immunoassay instrument that is sometimes used when hepatitis B testing orders increase. What should be the practice for this laboratory? Please select the single best answer. 1. Laboratories are not required to do comparisons on backup instruments. Only primary instruments require comparison checks. 2. The laboratory should do annual comparisons for the hepatitis tests in question. 3. The backup instrument and the primary instrument need to have results within 25%, and this must be checked twice a year. For the two instruments should have results compared twice a year if the backup instrument is used at all during the year. The answer. If the backup instrument is used at all during the year, then a comparison check must be conducted twice a year to verify that results are consistent between the two platforms. While a 25% acceptability target may be reasonable, the 25% number is not mandated. The acceptance criteria are up to the laboratory's medical director, and for qualitative tests a percentage may not be possible. The requirement is twice a year, not annually. The analytical measurement range, AMR, for your laboratory's serum glucose assay is 10 to 800 mg/dl. A sample is tested and the result is greater than 800 mg per deciliter. The clinician would like an actual concentration in this case. Which of the following is true? Please select the single best answer. 1. An upfront dilution could be made to bring the sample into the AMR. The result for the diluted sample should be mathematically adjusted to take the dilution into account. 2. If a manual dilution were made, the instrument reading for that sample would be the value you would report. 3. A result greater than 800 mg per deciliter can't be released without a new validation to extend the AMR. For a result greater than 800 mg per deciliter is not clinically meaningful. The answer. In this case, a simple upfront dilution could be done to bring the sample into the measurement range, AMR. However, when tested, the instrument result for that diluted sample cannot be reported without first accounting for the dilution factor and adjusting the result. Multiply the result by the dilution. Dilutions do not affect the AMR. A new validation is only needed if the AMR is changed. A result greater than 800 mg per deciliter may be clinically meaningful if the provider thinks this will affect patient management. A laboratory supervisor is considering establishing a delta check for serum iron and ferritin. Which of the following would be true? Please select the single best answer. 1. This delta check could save patients from being falsely diagnosed with anemia. 2. A delta check is reasonable for ferritin, but not for iron. 3. These two laboratory tests are not good candidates for a delta check. For delta checks are never used in hematology since values fluctuate wildly. The answer: ferritin and iron can change significantly over a short period of time. Such changes are often normal or expected, e.g., in response to diet, inflammation, and stress. Therefore, these two analytes are not good candidates for a delta check. Many healthy people would fail a delta check for ferritin and iron, making it a poor quality control indicator. A delta check for ferritin or iron would not help with anemia diagnosis. However, many laboratory parameters are relatively stable, more often those in the hematology section of the laboratory as opposed to chemistry, e.g., analytes such as RBC count and MCHC. A delta check could potentially be useful in some other setting or patient population, but not for ferritin and iron. You are preparing to work for the day, and while running QC for prolactin, you notice that level 1 failed. Level 2 and level 3 are within acceptable limits. What would be a good first step? Please select the single best answer. 1. You can proceed with testing patients, but monitor patients for trends and biases. 2. The assay should be recalibrated with a new lot of calibrator. 3. A new lot of reagent should be loaded and QC repeated. 4. Repeat the QC with a new vial of level 1 material. The answer: if QC is out, at any level, patients should not be run or reported. The assay may need recalibration or a new lot of reagent, but those steps should only be done if simpler solutions are not successful. It would be most reasonable to first try a new vial of the QC material to make sure that the QC sample itself hasn't deteriorated, been contaminated, or in some way expired. Your laboratory subscribes to a proficiency testing (PT) service that provided a sample to be screened on the immunoassay instrument for urine amphetamine. The test is positive. Like all positives, you send the sample to the toxicology laboratory for confirmation. Which of the following is true? Please select the single best answer. 1. You can only send the sample for confirmation if that is the way you would treat a patient sample. 2. The amphetamine result for the PT sample should always be positive, therefore, it does not require confirmation. 3. The PT result should be repeated to verify accuracy. 4. The PT sample must not be sent for confirmation. The answer: the PT sample should not be repeated and never sent for confirmation, even if this is how normal patients are treated. The PT survey must be performed blinded, and repeat or confirmatory testing is akin to cheating on the test by double-checking one's answer. PT samples can be positive or negative, the result is unknown and variable, and only revealed when the survey results are returned back to the laboratory. You have been given a set of proficiency testing (PT) samples to run on the chemistry instrument that you are operating for the day. Which of these procedures should you follow in performing the PT? Please select the single best answer. 1. Finish running all the patient samples, and then calibrate the instrument prior to testing the PT samples. 2. Have someone else repeat the testing and compare your results. 3. Perform all the tests in duplicate to verify that the results are correct. 4. Incorporate the PT samples into the patient run. The answer: PT test samples should be integrated into the routine workload, following the same procedure that is used for patient testing. Calibration was not performed prior to patient testing in this scenario. Therefore, it should not be done prior to PT testing. PT testing cannot be repeated by someone else. Repeat testing is only acceptable if patient samples are routinely repeated. If the laboratory policy is to repeat patient tests that are critical results, this can be done for proficiency testing samples as well, but samples that are not in the critical range cannot be repeated, as patient samples with similar results are not repeated. Your technical supervisor has asked you to verify the calibration for all your electrolyte assays. Which of the following is not an acceptable way to test method calibration? Please select the single best answer. 1. Use verification materials from the test system's manufacturer. 2. Use calibrators but run them as unknowns, to verify that the correct target values are obtained. 3. Use reconstituted QC to see if you obtain target values. 4. Retest previously reported patient samples. The answer. When checking calibration, all these options are acceptable except for using QC samples. QC samples serve the purpose of being controls and should not be used to validate a calibration. Instead, materials with identical matrices or actual patient samples should be used. If calibrators are run as unknowns, you should not use the same calibrators that were just used for calibrating the instrument. Use a different lot of calibrators. A medical laboratory scientist (MLS) is asked by a supervisor to run 3 assay verification samples provided by the manufacturer. The instrument and this assay were last calibrated 2 weeks ago. The last time the MLS ran the assay verification samples was 6 months ago. Which process is the MLS undertaking? Please select the single best answer. 1. Calibration verification. 2. Reference range verification. 3. Recalibration. 4. Instrument comparisons. The answer. The scenario above describes calibration verification, the testing of the current calibration to recover known results. The assay verification samples are target value assigned samples. Assay verification samples would not be used for the verification of reference ranges. Samples from healthy individuals would be used for this purpose. Calibration materials rather than assay verification materials are used for calibration or recalibration of the instrument. Testing assay verification samples ensures that the current calibration is still acceptable. The materials are not being tested on multiple instruments. Therefore, this testing is not being done to compare results from instruments that are used to test for the same analyte. Major maintenance was performed on the chemistry analyzer. Calibration verification is performed by testing the calibrators as unknowns to validate the calibration settings. However, calibration verification fails. What should be done in this case? Please select the single best answer. 1. Recalibrate the instrument. 2. Use a different method for calibration verification. 3. Run the daily QC materials to see if those values are acceptable. 4. It is acceptable for the calibration verification to fail once in a while. The answer. If calibration verification fails, the instrument should be recalibrated. Testing the calibration materials as unknowns is a straightforward way to determine that the correct calibration target values are recovered. Another method of calibration verification would also fail as it has already been shown that the current calibration settings are not correct. It would also not be acceptable to test the QC materials because these materials will not validate the calibration settings. It is never acceptable for calibration verification to fail. A chemistry laboratory supervisor discovers that serum creatinine testing has been performed for the last 8 hours, despite the fact that the low QC failed at the beginning of the shift. What should be done? Please select the single best answer. 1. Since only the low QC was out, any creatine value that is normal or high is unconcerning. Low creatinine results are clinically less significant, so no further action is needed. 2. The assay should be checked and once QC is back in, all reported patients since the shift started should be repeated. The laboratory's medical director can then decide if results need to be corrected in patient charts. 3. QC should be repeated. If all QC levels pass, then no further action is needed. For all low creatinine values should be run in duplicate and the average value of the duplicate should be reported. The answer. In this scenario, we have an assay that is out of control but was still used for patient testing. In such a case, once discovered, reporting should stop and the assay's performance must be corrected. Once troubleshooting is complete and QC is again within acceptable limits, patients that were run during the failure period should be repeated. The laboratory's medical director should then be consulted. Technical personnel can then use the laboratory director's criteria for what constitutes a clinically meaningful change and look to see if any results were significantly different upon retesting. Results that are deemed significantly different should then be corrected in the patient's medical record. A medical laboratory scientist, MLS, is performing his biannual analytical measurement range, AMR, study for beta-HCG. Since his laboratory is used to seeing pregnant women with HCG values greater than 10,000 μ/ml, he designs the AMR study to range from 5 μ/ml to 20,000 μ/ml. The assay's validated range is 5 μ/ml to 5,000 μ/ml. Which of the following is true? Please select the single best answer. 1. Samples above 5,000 μ/ml will need to be diluted for the AMR study. 2. The AMR should not exceed the validated range of the assay. 3. The AMR should extend to the highest concentration that can be seen in a laboratory's patient population. 4. The AMR should test at least 5 samples ranging from 0 μ/ml to 10,000 μ/ml. The answer. Since the AMR is the range of concentrations that an instrument can measure without any pre-treatment of the sample, dilutions should not be performed on samples used in the AMR. The AMR range should match the validated range for the assay and not factor in dilutions. One can change the reportable range for an assay with dilutions, but in this example, the MLS is trying to change or validate a new AMR. The AMR should not extend below the bottom of the validated range, so a sample of 0 μ/ml should not be used.
شكرا جزيلا للمشاهدة، واشوفكم ان شاء الله الفيديو الجاي، والسلام عليكم ورحمة الله وبركاته.